Hi, folks. Thanks for being here with us today. I am Mauricio Tohen. I'm a distinguished professor and chair of the Department of Psychiatry and Behavioral Sciences at the University of New Mexico, and it's a pleasure for me to be with you today. So today we're going to be talking about hot topics in mental health. Specifically, we're going to focus on bipolar disorder. Bipolar disorder has been in my area of interest clinically, research, and teaching for the last number of years. So hopefully we can add value to your practice. How do you present starting a long-acting injectable treatment for bipolar 1 patients that may be reluctant to receiving an injectable medication? So yes, when we talk to our patients about available treatments, let's say antipsychotics. Well, we talk about the different antipsychotics. We provide our knowledge of the data that shows the efficacy and the side effects, and not just of our own experience. That's an N of one. I think it's important also to let our patients know what the literature states when they're seeing a number of patients. So we provide that information. We also provide information about formulation. Some medications are available by mouth. Some medications are dissolvable or liquid, and some medications can be delivered intramuscular, including long-acting. So we would need to, of course, talk about the risks and benefits. The first question patients or point comment that patients are going to make, I don't like injections. Nobody does. I'm sure there are exceptions. So one should let patients know that studies have shown with the different available long-acting intramusculars that the pain or complaining of pain has been small, providing them with the numbers. For some patients, it matters if the medication is arm or gluteal. We provide that information. Another is that the length. Some of the injectables can be 1 month. Some patients might prefer that. Others might prefer 2 months or longer. So we provide those options. And a key point, let's say a patient decides that they prefer a 2-month rather than a 1 month. What is key is that should not be connected to how often the patient be seen. If the patient chooses to have an injectable every 2-3 months, etc., that does not necessarily mean that the patient should be seen every 2 or 3 months. If the patient needs to be seen weekly or every other week for other reasons, that's the decision. So the decision of how often should be independent of the injection. Now, if for convenience, of course, it's to see the patient the same day. Let's say we decide the patient, the patient decides, and we agree with every month or every other month, then ideally it should be the same day for a number of reasons. We check on adherence, and then it's, of course, the convenience for the patient. Now, side effects. Of course, the patient is going to ask, okay, if I take this medication by mouth or injectable, do I have the same side effects? And they are. Of course, the exception would be the pain in the site of injection, which is actually a few patients, or the numbers are very small. The other question is side effects. Are there more side effects? And the answer again is no. Now, do we start an injectable before the patient takes the medication by mouth? No, and it is recommended that first we see what side effects the patient might experience. If there's some side effects that are experienced by mouth, then of course the use of an injectable of that same medication might not be ideal. So those are important questions or important points to bring up to our patients when we start talking about long-acting intramuscular antipsychotics. Folks, I hope that this presentation was helpful. If you have any questions, please send them to us. And thank you for being here with us today.